Just would like to close with a couple of other sort of supportive care issues. Have anybody been using the shingles vaccine now in their patients, or are we still holding off? What's happening there?
Well, just I think it was this week, there was a report of a Merck shingles vaccine that was used particularly in the autologous stem cell transplant setting, showing efficacy, and there's a similar GSK vaccine that has been analyzed and has been reported in abstract form that also shows efficacy and safety in this setting. So yes, I have now.
Those aren't available yet, are they?
No, the Shingrix or the GSK is available, and I am starting to recommend this non-live vaccine for our patients with myeloma.
It would certainly be nice not to have to take acyclovir for years on end. So.
Yeah, I guess the question is, can you extrapolate the post-transplant vaccine strategy with somebody who's actively on therapy, particularly containing dexamethasone?
Or proteasome inhibitors, right?
Yeah, I mean, I think myeloma in general is a risk factor, but any therapy.
And daratumumab is also on label to have shingles prophylaxis.
Yeah, so I'm not yet ready to stop the oral antiviral prophylaxis, even if the patients receive the vaccine. In the clinical trials, they gave the oral prophylaxis for up to 6 months, I believe, after it. But it all so weighing risks and benefits. It's not necessarily the end of all VZV prophylaxis, but
okay. Let's go quickly into some two other very quick topics: use of anticoagulants in immune modulator patients. Aspirin or low molecular weight?
Low risk aspirin, high risk. I use a 10
antithrombin
10A.
inhibitor.
Yeah.
Same?
Same.
Anybody disagree with that? How often are you using the Eliquises or Xareltos or whatever is out there? Are you?
I mean, for high-risk patients, I would definitely use it if you can get it covered. I mean, that's the big challenge.
For older patients that have high tumor burden in that first cycle or two where the risk of thrombosis is highest, we may do it for a short term.
I saw a study, I can't even remember which, I think it might have been KPD or something. They had like a 10% DVT rate. Was that, did I miss that yesterday?
The
right?
carfilzomib combinations have an increased risk of DVT, yeah.
You think that's because of the endothelial activation?
Probably.
Yeah. Okay, last one is antibiotics in newly diagnosed patients. There's been some studies suggesting that's useful. Ajay, are you using antibiotics in your newly diagnosed patients?
Not routinely, but sometimes in the elderly, like this, not forever as was done in the team study from Europe, but maybe the first month.
Amrita, I'm going to give you the last word. Antibiotics in your newly diagnosed patients?
I'm just using Bactrim for PCP prophylaxis, but not...
you didn't believe the Levaquin story from...
We have a very, how can I put it, fervent ID department that feels very strongly about Levaquin resistance and demonstrated in our patient population, so no, not routine.
And with Bactrim prophylaxis, you may actually get the same effect.
All right, well, we've covered a lot of comorbidities there and management of symptoms. So this has been a terrific discussion. Before we conclude, I'd like to ask each of our panelists to provide a takeaway from this program, maybe a nugget from their practice that they can convey to the people watching. So Tom, we'll let you have your last word.
Sure. This is an amazing time for treating patients with myeloma with a plethora of agents. And I would say get familiar with all the regimens. Get familiar with daratumumab, pomalidomide, carfilzomib. Combine two of the potent drugs together with dexamethasone and you'll typically have a good response. And then dose reduce for toxicities and change drugs if you have toxicities. And then I do think that CAR T cells, we're all so excited about CAR T cells. In the next 2, 3, 4 years, we're going to go from the Hyundai to the Cadillac. And I think then we're going to cure patients with myeloma.
You should be Tesla.
I was thinking the same.
California.
Okay, go ahead.
I think there's an amazing number of choices and it keeps increasing. And I think what will be really exciting in the future is really to be able to personalize therapy more by genomic stratification, by MRD status. And I think that'll be really great for patients. So it's not just one size fits all, which is what it seems like we're doing right now.
Amrita, your takeaways from this meeting?
Well, I think to quote one of your colleagues, if you put 3 myeloma doctors in a room, you get 5 opinions. And I think that's a very good thing for patients because it speaks to the number of choices for them. And it's really, as Ajai said, individualizing therapy to mitigate toxicity and maximize efficacy.
Ed.
We've been so fortunate for our patients to have, over the last decade or so, developed so many wonderful new therapies that have enhanced their lives, and both in terms of quality, in terms of duration. And what I really took from this meeting is that that hasn't ended, that there still are new approaches, new directions, and my optimism continues to increase.
Last word to
Yeah, I mean,
Professor
I think with all of these new treatments and approaches, it's really important that we maintain a consistency of practice. And while each of us can have different flavors on how we do things, we have to build on what has gotten us to where we are today in order not to say this is just as good as what we were doing, but this is much better than what we were doing. And that I think is the challenge for all of us.
Well, thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us. We hope you found this peer exchange discussion to be both useful and informative.